Hello everyone, my name is Shayan Moosa. I'm a neurosurgical resident at the University of Virginia. I have the pleasure of working with Dr. Jeff Elias on a pilot study of focused ultrasound medial thalamotomy for the treatment of trigeminal neuropathic pain. We do have some disclosures. We've received funding from the Commonwealth of Virginia, the UVA Focused Ultrasound Center, and the Focused Ultrasound Foundation. So as you know, chronic pain is an enormous societal issue. This is evident by the fact that literally tens of thousands of people in our country are dying yearly from the abuse of prescription opioid medications. And this is a number that's only increasing with time. One of the major issues or reasons why this is occurring is that chronic pain is extremely difficult to treat. And that's particularly true for neuropathic pain, for which half of patients receive little to no benefit from medical or surgical treatments. Now, our surgical treatments for chronic pain are essentially based upon lesioning along the pain pathways. And this has evolved to target the medial pain system, and is actually derived from excellent work that's been performed in Zurich, from which we're basing our studies on. Now, the lateral pain pathway, which you can see in the picture here, known as the neo-spinothalamic tract, is very well understood and has fibers that travel through the VPM and VPL nuclei of the thalamus, and then travel rostrally to synapse in the sensory cortex. And this is thought to be primarily involved with the nociceptive or the discriminative component of pain. The medial pathways of pain, which also are known as the paleospinothalamic tract, are not as well understood. And these travel through the reticular formation, move rostrally to the centromedian parafascicular nuclei of the thalamus, which are more medially located, and also through the centrolateral nucleus of the thalamus, and then move rostrally to synapse in the limbic areas as well as the basal ganglia, which make us believe that this pathway is more involved with the affective components of pain, such as attention or arousal or emotion. So one would argue that it would be more important to create lesions within this area of the pain pathway, and that's supported by lesioning studies that have actually found good results, promising results in terms of pain relief from lesioning in that area, as well as promising safety profiles as well. One of the issues, though, with many of these studies is that they have been open label. They've also had very heterogeneous patient populations. In addition, they've had imperfect measures of pain outcomes. So our study is designed, hopefully, to address those issues. The objective of the study is to investigate safety and initial effectiveness of performing focused ultrasound lesioning of the bilateral medial thalamus, particularly the centrolateral nucleus of the thalamus. The indication is for severe treatment-refractory chronic trigeminal neuropathic pain, and it's designed to be a prospective, double-blind, randomized, sham-controlled clinical trial performed in 10 patients at the University of Virginia. Now, the axial T2 MRI that you can see here shows the expected lesion that you would see from this procedure, and this was actually performed in a patient published by Jean Monod et al. This here shows the design of our study. It begins with the screening process, which includes a CT and MRI scan. Our primary efficacy outcome measure is the NPRS, which is the numerical pain rating system or scale. It's an 11-point system that's well established. It essentially has a clinical rater asking the patient what their worst pain score has been in the past 24 hours. Our secondary efficacy outcome measure is the PROMIS inventory, which is a much more extensive inventory that looks at the overall health of a patient with a chronic medical issue. There are specific factors of this inventory dealing with pain that we'll be assessing. We'll also perform a complete pain psych assessment at that time. If the patient is deemed appropriate for the study at baseline, at the baseline assessment, we'll perform a PET scan. This will allow us to have an objective measure to compare to our clinical results. We'll repeat our NPRS and PROMIS inventory at that time. The patients are then randomized to either the test arm or the sham arm in a 1-to-1 fashion. So 5 patients will undergo the exablate treatment, 5 will undergo the sham treatment. And with the sham treatment, essentially the patients go through the same planning and procedure, but the power is set to 0 on the device. After the treatment, the patients will be assessed for any adverse events, which will continue at day 1, 7, 30, and 90 after the procedure. Repeat MRI, NPRS, and PROMIS inventories will be performed. And finally, after day 90, a repeat PET scan and psych assessment will be performed. After that time, patients will be unblinded and can be crossed over to the test arm if they wish. So far we've completed 3 patients as far as their assignments. Next time we meet in a year, I plan to have the results of the study, and we'll plan for more extensive trials in subsequent years based on those results. Thank you so much.
Questions for Shayan?
What are the stereotactic coordinates that you use for this ablation?
Sure. So we use F-gator imaging, and on that we can see very well the medial dorsal nucleus of the thalamus as well as the pulvinar. And essentially at the intersection, at the interlaminar area, that's where we're assuming the centrolateral nucleus of the thalamus to be. We make sure not to be more than 10 millimeters lateral to the midline as well. And this is about 6 to 8 millimeters superior to the ACPC line.
I see that you do PET scanning in this study. What are you expecting to see on PET studies?
At this time, I mean, we're using it basically, functional imaging to see any changes that occur. There are no specific areas. This is something we just wanted to try and see, what changes would occur. But in further studies, based on what we see, may be able to hone in on certain areas, but nothing in particular.
I just have a curious question. I've heard in previous sessions that when you do a bilateral lesion, the second lesion can sometimes be more difficult to achieve. I wonder if you find the same thing in your study so far.
Yeah, we have seen that before, and what we typically do is, if a patient has more symptoms on one side, we'll treat the contralateral side of the brain first in order to make sure to treat that side, and then go on to the other. We don't know exactly why it's harder to treat the other side. There potentially are changes that occur in the skull, but we have seen that there can be more difficulty with that.
Okay, thank you.
Thank you.
Thank you.